Hello and namaste. How have you all been? I hope that with the easing of lockdowns, you will be following the COVID safety precautions with even more care and focus. This is Dr. Srinidhi Chidambaram with the COVID Recover series presented by Apollo Hospitals. The Recover series focuses on key aspects of COVID-19 recovery and gives you all the relevant details so that your recovery process is smooth and quick. COVID-19 is now in all our minds, one way or the other, and the recent waves have touched someone in our family or someone we know for sure. Suddenly, words like NIV, ventilator, steroid, remdesivir, CT severity scores have become part of everyday conversations, leading to many myths and misconceptions too. One such word that is heard often these days is ECMO. Extracorporeal membrane oxygenation, or ECMO, is effectively an artificial lung or heart. The technology is used when all other forms of heart and lung support have failed for the critically ill patients. The type of pneumonia that is often associated with COVID-19 can cause long-standing damage to the alveoli or the tiny air sacs in the lungs. And ECMO is now being used to support critically ill patients with COVID-19 pneumonia or other forms of lung damage too, especially when their respiration is not sufficient to sustain blood oxygen levels. ECMO is for the critically ill, but it does not mean that one has reached the end of the road. There has been many success stories, and it has been life-saving in many instances. To discuss COVID-19 lung damage in detail and the role of ECMO in recovery, I am delighted to welcome Dr. T. Paul Ramesh. Dr. Paul Ramesh is a senior consultant cardiothoracic heart and lung transplant surgeon, as well as the coordinator of the extracorporeal life support system or unit at Apollo Hospitals, Greens Road, Chennai. He has established the heart and lung transplant program at Apollo Hospitals Group and has also established the multidisciplinary team for the management of advanced heart and lung disease. He has several remarkable achievements to his credit, such as performing the most number of heart and lung transplants in India and the most number of double lung transplants in India, as well as the first successful bridge to heart transplant. The oldest patients to receive a successful lung transplant in India and a successful heart and lung transplant in India were operated on by him. He has also performed Asia's first en bloc successful combined heart and liver transplant and the largest ECMO series in India for acute respiratory distress syndrome. Welcome, Dr. Paul Ramesh. I'm really happy to have you here talking to us on our COVID Recover series. And I do hope that you will be able to share your valuable insights on what really happens to our lungs in COVID-19 infection, how they recover, and what is the role that ECMO plays in survival and recovery. Over to you.
Thank you very much, Dr. Srinidhi. This is actually a very pertinent question because over the last 1.5 to 2 months, certainly the second wave of COVID, we've been inundated with calls from patients who want to know whether ECMO is something that they should be looking at. This is quite a desperate call because most of these patients are very sick or dying. And very unfortunately, in the second wave, a lot of them are extremely young. So over the last 2 months, I've received over 125 calls, I think it's about 127 referrals, asking whether ECMO is something that would be helpful to them. So just a little bit of a preamble. Extracorporeal membrane oxygenator, as you said, is really an artificial device that had evolved from cardiopulmonary bypass circuits that we used to use in open heart surgeries for well over 40-50 years. And it's a miniaturized form of the cardiopulmonary bypass, but a variety of technological advances have helped to make this available at the bedside in ICUs. So really it does the work, as you already pointed out, of the lungs alone, in which case we take the blood out from the vein, we oxygenate it, we remove the carbon dioxide, and we give it back into the venous side, which basically means that the patient's own heart is still pumping, but it's just receiving better oxygenated blood because the patient's own lung is not able to function. So this is a pure respiratory or a lung assist, and it's called veno-venous ECMO. And this is the most common form that is applied in patients with ARDS from any cause. So just tracing our history back a little bit, we've been using this device for the last 10 years at Apollo Chennai, and we've done over 230 patients we've helped with ECMO prior to the pandemic. This is largely consists of patients who had ARDS from a variety of causes. It could be bacterial pneumonias, other kinds of viral pneumonias like swine flu, poisonings, patients who are awaiting lung transplants, heart transplants, or patients who have post-transplant problems such as primary graft dysfunction. This is a very varying wide group of people who've been helped by it. The advantages of ECMO, especially in COVID. So what happens in COVID, I need to explain that a little bit, is that the first part of the infection of the virus is when the virus gets on into the upper airways, and that is usually asymptomatic or patient has very mild infections. But in patients who are not able to ward off the infection at this stage, the virus then climbs down into the lower lungs. And this is where the problem starts, because once the virus starts multiplying in what we call type 2 pneumocytes, it's a kind of a airway cell. So if you look at the structure of the lung, there is the air space on one side and the blood from the heart flowing on the other side. And they're actually together as one membrane. So we call it the alveolar capillary, or otherwise air sac blood vessel membrane. And this is the only interface through which the body can access oxygen or give out carbon dioxide. So when this gets in, when the type 2 pneumocytes, or the kind of air cells surrounding the air sacs, gets infected with the virus, two things happen. One is subsequently other cells in the lower airway begin to get infected, but also the body launches an attack on these viruses, and that is what's called the cytokine response. So one aspect of the immune response is the cytokine response. So this is really an army that has gone mad, because what it does is it starts attacking everything, including the lung and all other parts of the body, other organs. It asks the cells to start committing suicide, what we call apoptosis. And so eventually, when enough of the cells die, the organ fails. And when enough organs die, the patient dies. So what ECMO does is two things. One is, by going on ECMO, we can stop ventilating the patient. So over 20 years, we know for a fact that the ventilator itself, irrespective of the cause for the lung injury or the lung problem, can cause damage to the lung, and this increases the mortality by about 10 to 15%. So by taking the patient off the ventilator, or at least reducing the pressures at which the lung is exposed because of the ECMO, we can reduce the chances of the patient dying from ventilator-induced injury. The second and the more important thing is that by oxygenating the other organs of the body well and removing the carbon dioxide from them, this machine helps prevent multi-organ failure and sudden cardiac death as well, and thereby reduces the mortality. So these are the two main reasons by which we use ECMO. Of course, the downsides of ECMO are that because it's a synthetic artificial membrane, we have to give blood thinners so that the blood doesn't clot in these machines, and that can increase the chance of serious bleeding. And of course, infections, when they get entrained into the components of the circuit, can become very difficult to eradicate.
So is the lung damage caused by COVID-19, is it reversible in the sense that, do people eventually recover, or are there irreversibly damaged lungs as well?
Yeah, that's an excellent question. We're just learning a lot about this virus just now, but we can extrapolate from 2 or 3 streams of knowledge. One is from the SARS-CoV that happened in 2003 and other kinds of respiratory virus, as well as what we know from the H1N1 epidemic as well in 2009, as well as what we currently know in the last 1 year from the first wave of COVID. I'll answer this question in 2 parts. The first part is that there is very heavy and serious damage to the lungs as soon as there is acute lung injury and viral pneumonia in patients. So this is what we call the acute phase, or the acute lung injury phase. where there is a tremendous amount of, as we just said before, the inflammatory response itself, but also debris that gets from the damaged cells, from the viruses. And also what happens is it opens up the damage to other kinds of infections like bacterial and fungal infections. So all of this put together begins to clog up the airways. So not just the small airways, but also the air sacs themselves get filled up with this debris. Now, when this is there, oxygen cannot diffuse into the blood, nor can carbon dioxide come out. And what this does is it causes a great strain on all parts of the body, on all organs of the body, but especially the right side of the heart, because these patients are suddenly faced with a very high pressure against which the right side of the heart has to contract. And so the right heart can suddenly fail. And this two things together, the poor gas exchange, as well as the high pressures against which the right ventricle has to work, which basically means blood cannot get to the left side, is the main cause of sudden death in these patients. Now, in terms of the chronic damage to these lungs, or what you asked for in terms of fibrosis, what we are learning is that this fibrosis or scarring that occurs in COVID-1, it seems to be reversible to a large degree. So we are seeing patients who, even though they've been discharged, whether from ECMO or even from a ventilator, they've survived the ventilator, but they've gone home, they seem to be quite breathless and requiring some oxygen support. But this appears to keep coming down in the months to come. So even as far as 1 year, we see complete radiological resolution. By that we mean the CT scans get normal and the function of the lungs get normal. So to answer your question in short, it is not irreversible in everybody. It's very likely that a small subset, and we as yet do not have any clear data on who is going to suffer from that. But the large number of patients who have survived even severe COVID, the lungs appear to reverse the damage.
These days, we also hear a lot about the opportunistic fungal infections, which are all colorfully named by different colors by our media channels. But do you see a lot of that also affecting the lungs? And in those patients, does ECMO play a role?
Yes, ECMO plays a role whenever there is a damage to the lungs that is so heavy that the ventilator is unable to cope up with the amount of oxygen delivered or carbon dioxide cleared. So if you look at the lung per se, there are two aspects to its function. One, what we call the ventilatory function, which is nothing but the ability of the patient to move an adequate amount of air into the lungs. It does not matter if your lungs functioning well or not. You have to move, for example, a 70 kg person requires to move at least around 400 mils of air every time he takes a breath. Now, what happens in COVID or any other kind of stiff lungs is that not even about 50 or 100 mils is able to go in. So even if the lung per se is actually working well, we are unable to move large amounts of air in. And when the ventilator tries to move this high amount of air inside, the pressures go up. And that is what is damaging to the lungs. The second is because of the destruction of what we described, the air sac blood vessel interface, you find that there is very little oxygen going in and carbon dioxide coming out. So this can happen, this initially happens because of the virus damage, but usually opportunistic infections, as you told them, whether they are bacterial or fungal, and most of these fungus reside on our body, on the skin, the upper airways, but when they see a chance of a breach, then they move in and start infecting the patients. We have seen at least two kinds of fungus very commonly in these patients. One is Candida, and the other is Aspergillus. They are a consequence of not just the damage to the lungs, but the kind of treatment that patients are getting for COVID, namely extreme immunosuppression, either with steroids or with monoclonal antibodies. And this in turn reduces the body's chance of trying to fight out these opportunistic infections. And while we are on ECMO, we have a double-edged problem. We have to try to treat these while at the same time they can actually go into the spaces of the ECMO machine and become quite resistant to treatment.
It is indeed a double-edged sword.
Yes.
For a lay person, what would you, is there some way in which they can be more alert to the symptoms of lung damage? I know we tell them to measure their oxygen saturation, but Could you tell in simple words, like, what should people look out for? And is there any way to, revert, not to leave it till too long, somewhere to minimize the lung damage by probably recognizing symptoms early? Are there any such things?
Uh, this is a difficult question to answer without unduly scaring a lot of people into, as you said, measuring their saturations or their respiratory rate or seeing if they're feeling breathless or not. In patients who are experiencing symptoms for the first time, that they've not had COVID before, I think it's nice to remember that the vast majority of patients who develop COVID are, even if they do develop symptoms, are going to be fine. And this is even for patients who begin to drop their oxygen when they exercise. So some of it is also because a lot of patients are not fit. And so even a small increase in oxygen demand, the new lung is incapable of handling it. So the vast majority do not need to worry about anything, but they do have breathlessness. They have a cough that is not settling, and they are desaturating even at rest. Then I think that's something that they need to bring it to the attention of the doctor. The reason why they need to bring that to the attention of the doctor is the use of steroids or even certain kinds of monoclonal antibodies is best given, or even the new cocktail appears to be best given in the early stage, that is within 7 days. So when you if you miss the boat, then even these drugs are really not very helpful in reducing mortality. In patients who have suffered from COVID and have gone home, you can expect some level of inflammatory damage to persist. And so these patients could, have a low-grade fever sometimes, but more likely to have a cough, a dry cough that is not settling, some level of shortness of breath. And I don't think they need to worry as long as they continue to exercise, and diet appears to form a very important part of this. So as long as they're able to do that and they're able to progress in this on a day-to-day basis, they don't need to worry about it.
Which brings me really to the next question. You were speaking about diet and post-COVID, how to, the lung damage, how does it kind of how do people recover really? So what would you advise people in terms of, are there any special exercises that they must do or anything that they must watch on their diet so that the lung damage or whatever remnant is still there can get better soon?
Yeah, I'll limit my answer to very specifically in terms of lung and COVID. As far as the diet is concerned, and I think this is now quite prevalent in terms of a low carb diet, or certainly a low calorie diet, that is largely from proteins and carbohydrates. So if there is a measure in our body called respiratory quotient, that is the amount of carbon dioxide that is produced for the amount of oxygen that is consumed. So if you largely consume carbohydrate, then this respiratory quotient is equal to 1, which means that you are actually increasing the carbon dioxide production in your body, say compared to a more favorable diet which is high in protein and fat, because that tends to produce on the whole much less carbon dioxide. Now, usually as your lung is recovering, even if your oxygenation is adequate, the clearance of carbon dioxide takes some time to happen. And this is because the muscles of the body take a while to get better. So at that time, since your carbon dioxide elimination by your lungs is fixed, it makes sense to limit the amount of carbon dioxide produced. So overall, I think it's logical to say that a low carb, high protein, or a high fat diet may be more favorable. As far as the exercise part is concerned, I think most of the deep breathing exercises, use of spirometry, pranayama, all of that definitely helps to increase the main thing, which is the compliance of the lung. So much like muscles elsewhere in the body, the muscles that help you breathe, which is the muscles of your chest, the neck, and of course the diaphragm, all of them are muscles like anywhere else, and they have to be retrained. If you've been very sick in hospitals, then usually these muscles all take a hit. There is a condition called critical illness myopathy, and we see this in a lot of patients who come off ECMO. So right now, with the second wave of 15 or 16 patients we've treated, we've had about 2 patients go home in the last week, and we have about 2 more coming off the ECMO. The main issue is muscle weakness. And so to address this, just like we would train for any other part of the body, you need to train these muscles back to where they were. And so deep breathing exercises, as well as general cardiovascular exercises like walking, cycling, and everything, all of them definitely helps.
Is there some way to keep your lungs, is there a, if somebody gets COVID, so that the lung damage is limited, are there some predisposing factors for people to develop extensive lung damage or even other organ damage? Because we have been hearing of vulnerable groups like people with uncontrolled sugars. So what is it that people can do to keep themselves all fit to fight the infection and make sure that they don't go into the severe category, or is that something which is not in our hands?
It is to some extent in our hands, but it's an overall sense of being healthy. So one of the few things that people have shown is the data from the UK, which has suggested that as your BMI goes up by 1, you have a higher than 5% chance of being hospitalized with COVID. So for the same amount of, say, viral load or viral infection, the higher the BMI, the higher the chance of getting hospitalized for serious infections. In terms of what you can do in order to prevent it, is obviously get vaccinated. That appears to be one of the few things that appears to limit the spread of the virus, and also the degree of damage to the lungs, and the chance of hospitalization is reduced, chance of serious infections is reduced. Double mask, limit yourself, do not go out as much as you would like to. The deep breathing exercise and the diet we already spoke will definitely help. So all of these things, I think, the diet, the exercise, isolation, vaccination, all of it will reduce the severity of the disease, even should you get it.
We did speak about the role of ECMO in COVID-19, but let's talk a little bit more about it, as in at what point of time do we really, if a person is ill in hospital, what is the time when we decide that this person must have the support of the ECMO?
Yes, this is a very important question. So people have often projected ECMO as an alternative to ventilation. It's not that. It is actually the next step up. Like, for example, you're breathing through a face mask with oxygen. You're not able to cope with that. You have non-invasive ventilation, whereby you have a tighter mask, but you don't have a tube down your throat. And then the next step is a tube down your throat, what we call mechanical ventilation. And then the next step up is the ECMO. However, what I have to clarify here is the ECMO has a window in which it is most useful. By that I mean you could go in too early with the ECMO machine, and as I've already said, it's a double-edged weapon. So you really don't want to put people on ECMO much before they need it, or it becomes too late when they already have multi-organ failure and sepsis, or their airways are so damaged that they're very unlikely to improve. So you don't want to go in too late. But unfortunately, the assessment of this window is very specialized. How we do it is we have a set of scores by which we look, previously I told you about the ventilatory and the gas exchange function. So if the patient's lung becomes too incompliant or not compliant, it's getting worse and more stiff, or if the patient's gas exchange is getting poor, we have certain yardsticks for this that we pick up from the ventilator, the airway pressures, the levels of oxygen, for the amount of oxygen you give, levels of carbon dioxide and the rest of it. And then we make a score, and if that score is above a particular number, in Murray it's about 3, and it's progressing, then we think it's time to go in with the ECMO. However, if you have very significant bloodstream infections with sepsis and multi-organ failure, the ECMO is very unlikely to help you, because the damage that has been done by the multi-system inflammation has already happened. So this window, unfortunately, can be from just a few hours, but usually within a few days. The other thing is the number of days of ventilation. The data from the registry, we have a registry internationally called ELSO, to which we also contribute. That data is very clear in that if patients are ventilated for less than 7 days, ideally less than 5 days, their chance of surviving the ECMO and getting back to a normal life is quite high. If it is beyond 11 days, then the chances are not 0, but they certainly diminish. So there are 2 categories of patients. So this is how we assess whether the ECMO is going to be useful for a particular
What about, can we use ECMO because we do hear a lot about pregnant women developing severe COVID-19 and getting admitted into the ICU. In your experience, have you used it in pregnant mothers, or can it even be used? And
we have used it in pregnant mothers in the past, not in COVID situation, but it is the subgroup of patients who have pregnancy are at particularly high risk. I think it has to be clarified whether they are currently carrying, what month they are pregnant, or they've actually delivered. A lot of the patients appear to develop very severe COVID infections immediately after delivery, in the immediate postpartum period. ECMO, by definition, means that you have to thin their blood, and these patients are prone to bleeding even if they're otherwise normal. Pregnancy induces a particular kind of a situation where the chance of bleeding is quite high. Having said that, the world over, there are just a few numbers of published where they have shown success in patients. Most of them have been patients in whom they've already delivered the child, or the child is near term where a cesarean has been done, and then the patient has been put on ECMO. Most of the time, from what little data and anecdotal evidence we have, fetal loss seems inevitable.
And what about children? Because we have heard that, for example, in Apollo Children's Hospital, there have been quite a few cases where they have been on ECMO. So have you also used this on children, or what do you think about children getting COVID-19 in a severe way? Because one hears that it is not a possibility, it is extremely unlikely, but there's always this persistent thought that, children are going to get more affected, more severely affected. We don't know if it's true though. Even
yes.
in the coming
so in this 125 odd referrals that I told you about the second wave, I've had just one child who was 11 years old who was referred for COVID. But unfortunately, before the ECMO could get to him, he succumbed to his illness. I have not for COVID done ECMO on any children. We have done in the past patients who had respiratory illnesses. And children as a subgroup tend to do better from any kind of disease with ECMO. As a whole, children do better on ECMO than adults. Now, as far as COVID-19 is concerned, if you look at the pattern between the first wave and the second wave largely affected young adults because they were not vaccinated. So one of the concerns that everyone is raising is the largest group of people who are not yet vaccinated are children. So if the virus mutates enough to attack children's respiratory tracts, and they are the most vulnerable group now. I certainly hope that doesn't happen. But if it does, I'm sure just as in the young adults, ECMO will play a role in a subset of patients to help them recover through this illness. It hasn't happened as yet, and I hope it doesn't.
I hope it doesn't too. Doctor, now we will take some questions that are coming on our live feed from people who are watching this episode. So I'll just read them out one by one. What precautions can be taken or need to be taken while administering ECMO therapy?
Yes. So one of the first things that we do is make sure that the patient does not have a condition that makes them bleed excessively. So if these are patients who are already on a lot of blood thinners, or their blood is very thin because the platelet count is very low, or they have severe liver dysfunction, then we tend to think twice. We have certain numbers that we look at before we may or may not initiate ECMO therapy. So the patient should not have a bleeding diathesis, or a condition that increases their chance of bleeding. The next one is we try to make sure most of these patients are, as you know, they are prone. So they have neuromuscular blockade, they are sedated, they're unconscious. We try to make sure that we think that the patient is neurologically intact, because if you do it in a patient who's had a bleed into the brain, or who's had a stroke, it increases the chance of further bleeding into the brain. And so we do not want to worsen the neurological status of these patients. And if the patient is already, for some reason, brain dead or severely neurologically affected, then we would not initiate ECMO. Those are the main kinds of contraindications that we have. That apart, the other important part of the therapy is that the patient should have a reasonable expectation of survival with so risky an interventions.
Talking of this, I also wanted to ask you about proning. Could you explain a bit about, because this is now, it was there in one of the guidelines itself that there are some situations where people should practice proning even at home. So how does it all work and what is its role?
So when the patients who are lying completely flat, if you look at the actual anatomy of the lung, it's kind of divided into lobes, and the two lobes at the bases of both of the lungs, the right and the left lung, a large part of those are actually at the back. And so when you lie, especially in patients are a little heavy, then it kind of compresses these lower lobes, and it pretty much takes off more than half of the function of the lung. So by proning, what happens is it releases these lungs, it helps to inflate them, and also reduces the pressure that the chest is at. Now, the intrathoracic pressure, the pressure inside the chest cavity, is quite important, because that is the pressure that determines how much blood will return via the veins into the heart. So two things are happening here. One is more amount of the air sacs are being released to help work, and also the pressure inside the chest is released so that more blood can come into the right side of the heart. And that's how proning really helps. So to answer the kind of related question about ECMO, so virtually all of the guidelines suggest that once you reach a particular end of the road with the ventilator, say that you're not able to get, proning as well as the use of nitric oxide, which helps to, nitric oxide is a gas that you kind of breathe in through the ventilator. It helps to loosen up all the tiny blood vessels in the lung and actually improves the blood flow to various parts of the lung and improves oxygenation. So therefore, these two things, proning and nitric oxide, should at least have been attempted. What we have seen, and we get reference from across the country, that some ICUs prone quite routinely, some don't, some have access to nitric oxide, and some don't. But the guidelines suggest that both of these should at least be tried before we approach for ECMO therapy.
So at what point should somebody prone at home if they're not in a hospitalized situation?
Well, usually, I mean, this is quite interesting. A lot of patients would just do it themselves instinctively and find that they feel better. So if they, and that's for a reason, because, most of their lung capacity is coming from the back of the lungs, and lying on their back for a long time actually worsens it. Certainly they are doing it because it helps them feel better. So a lot of times it can be tried at home when they're having the saturations are a little bit on the low side, they're feeling breathless. If they feel better, then I think, yes, awake self-proning is a very reasonable thing to do.
What should pneumothorax patients do after COVID? And also if they only have one lung?
Yeah, it's a very involved question. Let me just say, but why does pneumothorax happen in these patients? This is one of the features of COVID. We have seen patients whose lungs, the consistency of lungs in patients who do get ARDS, certainly COVID, is like tissue paper or newspaper that's soaked in water. It's extremely fragile. And so any kind of high airway pressures begins to tear these lungs. But the lung also begins to leak a lot of air from all over its surface. And if this air collects between the lung and the chest wall, again, as I said, the intrathoracic pressure or inside the chest pressure goes up. And so you need to put in a drain to relieve it. So if you think you have a pneumothorax, so somebody's looked at an X-ray, you have to immediately go to an emergency room, because this could be self-limiting and nothing to worry about, but it has to be ruled out by a doctor because it can be quite life-threatening. This can actually cause sudden cardiac death if it becomes a tension pneumothorax. So you will need a chest drain, and I would suggest you don't do anything. Just take slow breaths, see if you can use oxygen, because pure oxygen will prevent the pneumothorax from growing quite quickly, but get yourself to an emergency room as quickly as possible. Sorry, what was the second question? If they have only one lung, yes, it's even more serious when you have one lung. If you develop a pneumothorax on that side, because collapse of that lung will lead to immediate cardiac arrest, as you'll have no lung that's functioning. So patients who have had a pneumonectomy or had surgery where one lung has been removed, any kind of breathlessness, they should present to an emergency room straight.
Another question is ECMO safe?
Well, it's let's say that it is a high risk, high benefit intervention. It is highly invasive, it is very labor intensive, and it is to be done only in units that are kind of specialized to do it. So now a lot of units do acquire ECMO machines, especially over the pandemic, and they may be able to initiate it, but it's not really only about that. It's about maintaining these patients for a long term. Our average patients who got well have had to be on ECMO for 4 or 5 weeks. We have one patient now is coming up to 50 days. So this, to be able to maintain somebody on ECMO for that long requires very, very specialized expertise. So in that sense, it is a risk. I can actually quantify the risk for you. In the subgroup of patients that we select in COVID for ECMO, without the ECMO, their mortality approaches 95 to almost 100%. And in that subgroup, we have a 40% survival on average. We are functioning possibly at slightly higher than that, but that's about an acceptable international survival is around 40%. So that's the risk. It's a 60% mortality in patients, but you have to view it through the prism of that these patients have no other option.
Sir, it's been a month now since I've recovered from COVID, but I'm still having dry cough, which sometimes remains for a day and then goes away and comes again after some days. So,
sorry, dry cough, I didn't get the latter part of the...
just the dry cough, which sometimes is there for a day, then goes away and then comes back again after a few days.
Yes. This is quite classical of anybody who is recovering from pneumonia. There is still an ongoing low level of inflammation that is contributing to this. Some of these patients who develop a condition called BOOP, which is nothing but debris that is collected it with an ongoing inflammatory state. Now, I think if the cough is persisting and is associated with shortness of breath, they have to show themselves to a physician or to a pulmonologist to make a diagnosis. Some of these patients may benefit from steroids. Some of them may have an ongoing or a secondary infection which may require treatment. So, but otherwise, most of the time it should settle.
I have been, somebody has been on ECMO for 17 days, no improvement in lungs. All organs are normal. Is it chance of recovery? Can we wait for some more weeks, or is transplant the only option?
Okay, that's a commonly asked question. It's a difficult one to answer very specifically for this patient without me having seen the patient. I'll stick to some general points. The answer is worldwide, if you look at the data from the registry, a median time of stay is at least around 18 to 21 days before you can expect recovery. Our own experience at Apollo Chennai has been that patients recover, at least they have been on ECMO for about 4 weeks. So just as this thing, 17 days is still early days. However, the CT scan is a good guidance. If the patient still shows significant levels of inflammation or infection, which is really ground glass opacities are there, then it is worth persisting on the ECMO and hoping for resolution, given that it's only been 17 days. However, if there are signs of a lot of cystic spaces or honeycombing on the CT, which shows fibrosis, then the chance of recovery is not that good. However, having said this, the same registry data shows that up to 14 to 15% of patients, even on long-term ECMO, it is beyond 4 to 6 weeks, do at 90 days show improvement in their lungs. Let me put it another way. In the United Kingdom, people have stopped listing patients for lung transplant who are suffering from COVID because they have seen recovery even at late stages, and more importantly, I mean, not patients on ECMO, but for other patients, it appears that the lung fibrosis resolves in the long term. Now, lung transplant is a highly invasive and it's got a limited time frame and has been used largely in patients who have irreversible lung disease. The question here is this patient truly irreversible or not? And that's something that we have to examine the patient and take into account many things. But from our personal experience, I think if there are signs of inflammation on CT scan, it is worth continuing to wait, considering that all other organs are still functioning well.
Is age a criteria for selection for ECMO?
It isn't, but comorbidities are. This question has to be answered through the prism of resource utilization. ECMOs are limited in number, and the number of units that have true expertise in them are even further limited. It's not just about the doctors, it's about cardiothoracic surgeons, anesthetists, and intensivists, but also perfusionists and nurses who have a special training in taking care of patients with ECMO, physiotherapists, because a large number of our patients are actually extubated and they're awake, and this requires a lot of nursing. So therefore, there is a limitation in the number of people that we can help. So to answer your question a different way, all else being equal, people may defer towards the younger patient, but we don't make the call on just the age alone.
Which type of ECMO is easy to maintain, VV or VA? I mean, with less complications.
Yes. So the reason that you might put somebody on VA or VV is completely different. As I said, the majority of ECMOs for COVID, where only the lung is damaged, we do what's called VV. It is the lesser invasive, more easier to maintain. A VA ECMO is in our current group of 15, 16 patients. We had to use VA only once. It happens when the COVID affects the heart as well, or the heart is affected for some other reason, say that person has coronary artery disease and had a heart attack because of the COVID in the lungs. Then we do have veno-arterial, where both the heart and lungs are being supported. It is a far more invasive kind of ECMO and requires more work.
The last question is, can ECMO be done before intubation? I don't know.
It can be done. The question usually arises most of the time, virtually all the time, we would intubate the patient. But sometimes these patients have such stiff lungs that you're unable to ventilate these patients. So either they're very stiff or they're so soft that they start tearing even at the smallest airway pressures. And you will start losing the volume of air you're giving into the lungs to the outside of the lungs. So in those two situations, you can go on ECMO very quickly. But by and large, the majority, absolute majority of patients would have some level of intubation, usually at least for about 24 hours before they go on ECMO.
Thank you, Dr. Paul Ramesh, for the wonderful discussion. I think we had a very detailed explanation from you about lung damage, and I think our viewers would have had all their doubts cleared about ECMO as well. Thank you so much for sparing time from your very busy schedule and joining us on this discussion. Viewers, thank you for participating. Do watch out for our next session, which is on 22nd June at the same time, which is 2 p.m. We're going to talk about long COVID, that is the long-term effects of COVID infection. And this is going to be discussed by Dr. Sai Praveen Haranath. Do subscribe on our YouTube channel as well to get the latest information on our trending health topics. And if you have more queries, do reach out to us on our Facebook Messenger or post them in the comments section. And till we meet again, take care, be safe, and don't forget SMS, which is social distancing, wearing a mask, and sanitizing as often as possible. Till then, take care, be safe. See you on Friday. Namaste.